TMJ Pain. Does management using a myofascial or exercise approach help? TMJ pain is common and represents one of the chronic musculoskeletal problems frequently seen by chiropractors. In addition to mild adjustive techniques and postural rehabilitation, many chiropractors utilize an intraoral myofascial approach and often give self-care exercises as part of a management plan. A recent publication addresses this management approach in a randomized controlled trial. Published in 2012 in the Journal of Manipulative and Physiological Therapeutics, this study is entitled Intraoral Myofascial Therapy for Chronic Myogenic Temporomandibular Disorder, a randomized controlled trial by Colomer et al. This very interesting study has practical clinical implications for TMJ patients, and conducted in a private practice setting, it may have some value from the perspective of feasibility. Let's use this study as an excuse to do a brief overview of TMJ disorders, their prevalence, overlap with other conditions, and a short practical exam approach. Then we'll look at the specifics of this study and its results. Studies on the prevalence of TMJ pain suggest that 40 to 50% of individuals will have TMJ symptoms. Using a temporomandibular disorder questionnaire, Nomura et al. Found that of a group of students, 53% showed some level of TMD, 36% had mild TMD, 12% had moderate, and 5.5% had severe TMD. In evaluating the severe responders, women were about 9 times more affected than men. Of those who had any level of TMD, many considered themselves tense people, clenching or grinding their teeth, and also reported clicking of the TMJ. However, it must be recognized that clenching and grinding have not been consistently found to be initiators of TMD. Important for chiropractors is that 65% of TMD patients reported frequent headache and 61% had neck pain. It's clear that positioning of the neck has a dramatic effect on jaw positioning, and so therefore this relationship to headache and neck pain is not surprising. Additionally, patients involved in whiplash-type injuries often have secondary involvement of the TMJ. Let's do a quick overview of TMJ anatomy and function before proceeding to the history and examination. We can see on this lateral cadaveric view that there is a disc in between the mandibular condyle and articular eminence. It has 3 components: an anterior band, posterior band, and an intermediate zone. The condyle should always rest in the intermediate zone for smooth opening and closing. Various pathologies or trauma may seat the condyle posterior of the intermediate zone with anterior disc displacement. As a result, the condyle may reduce back to normal during opening with a click, or not reduce, remaining posterior without a click in a condition called closed lock. Less commonly, the condyle may displace anterior to the anterior band in a condition known as open lock. Here's a simplified graphic of the left TMJ. Note that the lateral pterygoid is pulling forward on the disc and condyle. Posterior to the disc is the retrodiscal tissue. Important to the clinical presentation is that the disc is not sensitive to pain, but the retrodiscal tissue is highly sensitive to pain. Now, let's look at a coronal view, a cross-section taken from anterior to posterior. Here, we more clearly see the joint capsule medially and laterally around the condyle. We also see the lateral pterygoid again. Why? Because it runs obliquely and therefore pulls in more than one plane. Now, let's look at normal opening and what happens at the TMJ. As the mouth opens, the closing muscles, primarily the masseter and temporalis, should relax. After 1 centimeter of opening, the inferior head of the lateral pterygoid pulls on both the disc and condyle. Rotation occurs in the first third of opening. This is primarily occurring between the inferior articular disc surface and the condyle. Further opening occurs with translation down the slope of the articular eminence to a point at which the condyle is slightly past the center of the eminence, still seated in the intermediate zone of the disc. Now let's watch this movement on real-time MRI and watch the relationship between the disc and the condyle throughout the movement. Let's look at what happens when the disc is displaced anterior in relationship to the condyle, with the condyle resting in the posterior band of the disc with the mouth closed. With mouth opening, the condyle is pulled forward back into the intermediate zone with a click. There may be what is called a reciprocal click just short of full closure when the condyle again moves posteriorly. Other movement patterns include lateral movement of the mandible caused by ipsilateral contraction of the temporalis and masseter muscles and contralateral contraction of the medial and lateral pterygoids. Protrusion is the result of forward movement of the condyles through contraction of the lateral pterygoid combined with forward movement of the mandible caused by contraction of the masseter and medial pterygoids. Let's move on to the clinical presentation through a brief discussion of signs, symptoms, and the TMJ-specific exam. The first consideration is that when the TMJ is involved, it may create both local signs and symptoms, but also other nonspecific signs and symptoms. The confusion and tendency to overlook the TMJ as a source of a problem is that there are many associated non-localizing symptoms, including headache, ear pain, ipsilateral face pain, tinnitus, vertigo, neck stiffness, and sinus congestion. Let's look at headache as a point of differentiation. You might ask, is a chronic headache a TMJ problem or a tension-like headache? What may help are distinctions that require an evaluation of TMJ involvement. With the TMJ, expect tenderness of the pterygoids, tenderness and clicking at the TMJ, and abnormal mandibular movement patterns on opening and closing. Here are some obvious and not so obvious historical clues. Primarily, one looks for direct trauma to the TMJ or indirect trauma to the cervical spine, and symptoms and signs of popping, clicking, crepitus, locking, or pain on closing or opening. Secondary questioning should include whether other joints are involved, and importantly, whether other conditions, such as RA or seronegative arthritides, are evident in the history or clinical presentation. These autoimmune disorders have a higher incidence of TMJ involvement. Given that the painful structure of the TMJ is primarily the retrodiscal tissue, let's consider the following in our history search for potential mechanical causes of injury or pain to this tissue. First is condylar compression from anterior disc displacement. Secondary, a hypertonic temporalis muscle. Third, a vertical height reduction, which displaces the condyle up and back, found with those with severe bruxism. And finally, a direct blow to the jaw. Now to the most obvious, clicking and popping. Clicking and popping may be entirely benign or may represent actual pathology. The distinction is based on when clicking occurs and whether there is aggravation of pain with additional challenges. Is the clicking or popping on both opening and closing? It's likely that there is disc derangement with reduction. If on opening only, a displaced anterior disc is most likely. Let's combine these findings into a basic exam for the TMJ. This includes three major components: palpation for clicking and popping and tenderness, mandibular gait analysis for abnormal movement patterns, and a dynamic challenge with contraction, compression, and stretch. By inserting a gloved finger into the external auditory meatus, clicking and popping can more easily be felt. Palpation that elicits tenderness behind the TMJ may indicate irritation of the retrodiscal tissue. Palpation externally and intraorally for specific muscle tenderness is also important. Use a simple drawing to map out both the degree of opening and lateral movement left and right, but also indicate any deviation from a smooth uniplanar movement pattern, and note when clicks occur. This is often done using calipers measuring movement in millimeters. A more crude approach is having the patient place as many knuckles in their mouth as possible. Generally, 3 knuckles would be considered normal opening. Next, we want to challenge the TMJ for pain using the following. If stretch causes pain, consider capsulitis. If compression causes pain, consider synovitis. And if resistance to movement causes pain, match this with the specific muscle or muscles that cause that specific movement pattern. Let's discuss synovitis first. The TMJ has a synovial aspect superior to the articular disc, which is often damaged or irritated. Any sudden compressive force superiorward would cause an immediate reaction. Chronically, this can be caused by articular disc degeneration. As always with testing, we want to recreate the mechanism, so we'll apply an upward compressive force through the mandible. Coupled exam findings indicating synovitis are tenderness at the posterior joint anterior to the external auditory meatus, pain worse with full closure, and possible relief by inserting a tongue blade between the back teeth. Next, let's look at capsulitis. Unlike synovitis, which is generally a compressive mechanism, capsulitis is usually due to overstretch, such as occurs with a wide yawn, long dental procedures requiring the mouth to remain open, or secondary to a whiplash-type injury of the neck. Again, we want to reproduce the mechanism by drawing down on the mandible, placing our gloved hands inside the mandible and slowly dragging down. Additional clues for capsulitis include pain worse with any of the following: wide mouth opening, protrusion or lateral deviation of the mandible, and contralateral chewing. Using the function of the lateral pterygoid as our logic, challenging through movement and resisted movement patterns may reveal a dysfunctional muscle. Resisted jaw protrusion or lateral deviation to the opposite side and resisted jaw opening can be accomplished easily through a single hand contact upon which the patient can push. Now, let's match movement and other findings to specific disc pathology. For disc derangement with reduction, expect open and closing clicks. This clicking can often be eliminated with posterior placement of a tongue blade on the same side. Next, a closed lock. Often secondary to whiplash injury, a closed lock is caused by an anteriorly displaced disc that blocks movement because of the relative posterior relationship of the condyle. There is tenderness at the TMJ, and the patient is unable to open fully. There are no clicks because the condyle never reseats itself in the intermediate zone. Compression is uncomfortable, but not very painful. So how valuable is the clinical examination for the diagnosis of TMJ disorders? Decent. In one study, the diagnostic accuracy overall was 83% for determining a normal disc-condyle relationship, 72% for diagnosing anterior disc displacement with reduction, and 81% for diagnosing anterior disc displacement without reduction. Now some management approaches. Some summary statements can be made regarding the literature support for manipulation and exercise in the management of TMD. There have been several very small studies and case studies that are promising for manipulation, but in no way definitive. Adjusting or manipulating the TMJ should only be attempted after hands-on instruction and mentoring have occurred. The evidence for exercise is stronger with more studies and more consistent results over time. However, none were compared with myofascial approaches in a randomized controlled study. So now to this study. Let's look at the patients in this study. There were 93 patients. Inclusion criteria for patients were that they were between ages 18 to 50, jaw pain of at least 3 months, and willingness to participate and contribute to long-term follow-up investigation. Exclusion criteria included if they were prior patients of the treating doctor, toothlessness, malignancy over the past 5 years, and fractures, dislocations, infections, inflammatory diseases, metabolic disorders, and other conditions. Additional discrimination included the use of what is called the Research Diagnostic Criteria, RDC. The RDC for secondary inclusion-exclusion criteria included identification of those with myogenous TMD, a minimum baseline graded chronic pain score of 3 of 10 on each of the 3 symptom outcome measures, and a secondary exclusion criteria was a finding of severe depression on the RDC psychosocial assessment. The primary outcome measure was pain based on an 11-point graded pain scale for jaw pain at rest, jaw pain upon maximum active opening, and jaw pain upon clenching. A secondary outcome measure was intracisal range of opening in millimeters measured by calipers. A change of greater than 9 millimeters was considered to be clinically significant. Patients were randomized into 3 groups: an intraoral myofascial therapy group consisting of 2 treatments per week for 5 weeks, an IMT plus education and self-care exercise group, or a weightless control group. The protocol for the intraoral myofascial therapy group was to perform an intraoral temporalis release, an intraoral pterygoid release, and an intraoral sphenopalatine ganglion technique. It's difficult to explain these techniques with enough detail to convey the skill of application. The listener is directed to the written description in the article, which is accompanied by photographic representations. The second group received the IMT protocol and in addition followed the IMT exercise protocol. This included a scripted short lecture by the practitioner for 2 minutes at the conclusion of each of the first 4 visits. It included a discussion of basic TMJ anatomy, biomechanics, disc displacement and dysfunction, the role of psycho-emotional factors in TMD, and mandibular exercises to be performed at home twice a day, morning and night. These exercises included a mandibular body condylar cross-pressure chewing technique and post-isometric relaxation stretches. Let me give a brief explanation of how these were performed. For the mandibular condyle technique, the patient alternates the following. They place the thenar of one hand on the condyle of that side and the other hand on the mandible of the other side. As the patient opens and closes 5 times, the patient applies equal pressure on both sides. For the post-isometric release approach, the patient applies the heel of their hand to their jaw. They first perform an isometric contraction for 10 seconds, pushing medially while resisting with their mandible laterally. Then the chin is contralaterally laterotruded incrementally, and the procedure is repeated from that point. This is then repeated on the opposite side and also with opening. So what were the results? Both intraoral myofascial therapy and a combination approach with exercise were superior to no treatment of chronic myogenous TMD over the course of 1 year. Most notably, the combination of IMT plus exercise and advice was superior to IMT at 1 year, although not apparent at 6-week and 6-month follow-up. What was the degree of effect? Let's look at the mean score changes for the primary outcome measure of pain at rest, opening, and closing. We can see that the mean score changes at 1 year were significant and greater for the myofascial plus exercise group, substantially higher for opening and clenching pain, especially when compared to myofascial treatment only. Let's review some of the weaknesses and strengths of this study. Some weaknesses were that there was only a single practitioner providing treatment. The advantage is consistency, but then we don't know if a group of practitioners with their inherent differences would fare as well or better. The patients were select in that they were referrals from a dental practice. Primary presenters to a chiropractic office may be a different subset of patients. It's difficult to know the adherence to the exercise approach, especially over a 1-year period, and it was difficult to control and therefore know if patients sought other care during that 1-year period. Strengths included that this was an RCT with long-term follow-up. The fact that this occurred in the real-world setting of a private practice may be of value in demonstrating at least the feasibility of application in other practices. All in all, this is a well-conducted study which should set the stage for larger studies.